The silence in the pre-op room was shattered by a single, desperate whisper. A name. A name that should have been forgotten. A name that belonged to a ghost. The elderly patient, lost in a haze of fear and medication, cried out for a child he never knew. And that name, it was the same. The same as the doctor's son. The son who took a single breath and then was gone. A lifetime of love condensed into a single heartbreaking moment. In that sterile, fluorescent-lit room, two worlds collided. A man facing his own mortality called out to a memory, and the man tasked with saving him was forced to confront the one wound that never healed. My name is Margaret, and in that moment, I was the only one standing between a surgeon's shattered composure and a patient's fragile life, holding my breath as a decades-old secret threatened to unravel everything. The morning had started with the gentle, predictable rhythm I had come to know so well over my 15 years as a cardiac nurse. The sun was just beginning to paint the sky in soft hues of orange and pink outside the large windows of St. Jude's Hospital, its light catching the dust motes dancing in the sterile air of the corridor. My first stop was always the same, the small on-call room to pour myself a cup of the notoriously bitter, tar-like coffee that was both a curse and a necessary sacrament for the long hours ahead. I remember the warmth of the cheap ceramic mug in my hands. A small comfort before the day's symphony of beeping monitors, hushed voices, and the profound, unspoken anxieties that filled every room. My assignment for the day was Mr. Alastair Finch, a 78-year-old man scheduled for a complex triple bypass, a procedure that held the weight of his entire future within its delicate, precise steps. He had been admitted the night before, and I had done his initial assessment, a gentle man with a shock of white hair and eyes that held a lifetime of stories, currently clouded with the fear he tried very hard to conceal behind a frail smile. When I entered his room, the scene was one of quiet preparation. The blinds were half closed, casting long shadows across the bed where Mr. Finch lay, the crisp white sheets seeming to swallow his slight frame. His daughter, Sarah, a woman in her late 40s with the same kind eyes as her father, was sitting in the vinyl chair beside him, holding his hand and speaking to him in low, soothing tones about her garden, about the roses that were just beginning to bloom. It was a desperate attempt to anchor him to something beautiful, something beyond the cold reality of the operating table. I went through my checklist with a practiced calm, checking his vitals, confirming his NPO status, and reviewing his chart. His pulse was a little fast, a frantic bird fluttering against my fingertips. A completely normal reaction for a man about to have his chest opened and his heart stopped. I adjusted his IV line, my movements slow and deliberate, wanting to project nothing but competence and peace. "The team is the best in the state, Mr. Finch," I told him, my voice soft but firm. "Dr. Thorne is a brilliant surgeon. You are in the very best of hands." He just nodded, his gaze distant, and squeezed his daughter's hand a little tighter. It was then that Dr. Thorne entered the room, and the very atmosphere seemed to shift. Dr. Robert Thorne was a man carved from marble in silence, a figure of such immense professional stature that he commanded respect without ever having to ask for it. He was in his late 50s, with silver streaks at his temples and a gaze so focused it felt like a physical force. He moved with an economy of motion that spoke of thousands of hours in the OR, every step, every gesture purposeful and clean. He was known for his flawless technique, his impossible calm under pressure, and his profound, almost intimidating reserve. He never engaged in small talk. His conversations were strictly clinical, a series of precise data points and procedural facts. We all knew not to take it personally. It was simply who he was, a fortress. He greeted Mr. Finch with a curt nod, his eyes scanning the chart I handed him. "Mr. Finch," he began, his voice a low, steady baritone that held no room for tremor or doubt. "We'll be taking you down shortly. The anesthesiologist will meet us there. The procedure has high success rates, and your pre-op labs look strong." It was the same speech he gave in some variation to every patient. Professional, detached, reassuring in its sheer lack of emotion. But as Dr. Thorne spoke, outlining the mechanics of the bypass machine in dispassionate terms, I saw Mr. Finch's attention waver. The clinical words were not what he needed. The fear in his eyes was deepening. His breathing became shallow, and he started to mumble, his words slurred slightly from the preoperative sedative beginning to drip into his system. He was no longer listening to the doctor. He was retreating inward to a place only he could see. His daughter leaned closer, her brow furrowed with worry. "It's okay, Dad. I'm right here. Just listen to the doctor." But Mr. Finch shook his head, his eyes glassy, fixed on some point on the ceiling. He was a man adrift, reaching for a lifeline in the fog of his own fear. And the name he found, the one he cried out with such raw, desperate need, was the one that should have never been spoken in that room, to that man. It was a name that belonged to a ghost, a secret buried so deep within Dr. Thorne's fortress of a heart that its utterance was like a seismic charge. And in the echoing silence that followed, I watched the surgeon's perfectly composed world crack right down the middle. The name hung in the air between them, a spectral presence that sucked all the sound and oxygen from the room. "Lucas!" It was not a shout, but a whispered plea, torn from the very depths of Mr. Finch's soul. For a moment, nothing moved. The dust motes seemed to freeze in the slanted morning light. Sarah's hand, which had been a comforting weight on her father's, tightened into a white-knuckled grip, her eyes wide with confusion as she looked from her delirious father to the statue-still doctor. I felt my own breath catching my throat, a sharp, painful knot. I knew. In that single, horrifying instant, I knew exactly what that name meant. It was a piece of hospital lore, a tragedy from nearly 2 decades ago, whispered about only in the most hushed tones during night shifts. Dr. Thorne and his wife had lost their son, Lucas, at birth, a perfect, full-term baby, gone in a single cruel breath due to an unforeseeable and catastrophic complication. The grief had sculpted the man Dr. Thorne had become. It was the unspoken foundation of his impenetrable reserve, the source of the profound silence that enveloped him. Dr. Thorne did not flinch. He did not gasp or stagger. The reaction was far more terrifying in its subtlety. The chart in his hand, which he had been holding with such effortless authority, seemed to become an impossible weight. His knuckles, pressed against the white plastic, turned a bloodless, stark white. The steady, low baritone of his voice simply ceased, cut off as if a switch had been thrown deep inside him. His eyes, which moments before had been focused on the clinical data before him, were now locked on Mr. Finch, but they weren't seeing the elderly patient anymore. They were looking through him, into a chasm of memory so profound and painful that a faint, almost imperceptible tremor ran through his jawline. The fortress walls, so meticulously built over 20 years, had not just cracked, a whole section had been vaporized by that one innocent, devastating word. The professional mask was still technically in place, but behind it you could see the raw, bleeding nerve of a father's agony exposed for the first time in this room, under these fluorescent lights. Time, which had frozen, now began to move again in a strange, slow-motion panic. Mr. Finch, oblivious to the cataclysm he had triggered, continued to mumble, his head lolling slightly on the pillow. "Lucas, my boy, don't be scared," he slurred, lost in a decades-old memory of comforting his own son, perhaps during a childhood fever or a nightmare. The juxtaposition was heart-wrenching. One man remembering a long life with a son, the other remembering a son who never had a life. Sarah, utterly bewildered, looked at me, her eyes pleading for an explanation I could not possibly give. "Dad, shh, it's okay," she whispered. "Lucas isn't here. It's me, Sarah." Her words, meant to soothe, only hammered the name deeper into the silent, wounded space between the bed and the door. My nursing instincts, honed over 15 years of managing crises, kicked in with a surge of adrenaline. This was no longer just about pre-op vital signs and procedural checklists. This was a critical human event, an emotional code blue. And the most unstable person in the room was the one holding the scalpel. I took a small, deliberate step forward, positioning myself slightly between Dr. Thorne and the patient, not as a barrier, but as a bridge. "Mr. Finch," I said, my voice deliberately calm and louder than necessary, wanting to break the spell, to anchor everyone back in the present moment. "Mr. Finch, can you look at me? It's Margaret, your nurse. You're safe. We're getting ready to take you to the OR now." I reached out and adjusted his oxygen cannula, my movements slow and visible. A performance of normalcy for the benefit of everyone in the room. I dared a glance at Dr. Thorne. He was still paralyzed, his gaze hollow. The chart in his hand was now trembling visibly. "Doctor," I said, my tone shifting to one of professional urgency, forcing him to engage with me on clinical terms. "His blood pressure is creeping up, 150/95. Perhaps we should consider a slight adjustment to the pre-op sedation before transport." I was giving him an out, a clinical problem to solve, a thread to pull him back from the abyss of his own grief. For a terrifying second, I didn't think it would work. He blinked slowly, as if waking from a deep sleep, and his eyes, when they finally focused on me, were those of a stranger, haunted and vulnerable. He looked down at the chart, then back at Mr. Finch, and I saw a brutal war being waged behind his eyes. The surgeon fighting the father, the healer wrestling with the wounded. The fate of a patient hung in the balance of that internal struggle. He gave a curt, almost jerky nod. "Yes, see to it, Nurse Margaret," he managed, his voice a rough, strained version of its former self. He didn't look at Mr. Finch again. He turned on his heel and walked out of the room, his steps not quite as sure and silent as they had been when he entered. The door hissed shut behind him, leaving Sarah, her sedated father, and me in a silence that was now thick with unspoken tragedy and looming professional dread. The surgery was in less than 30 minutes, and the man who was supposed to perform a miracle on a human heart had just had his own broken wide open. I find that stories like this, born in the quiet, intense moments of a hospital, have a way of connecting us all through our own shared experiences of love and loss. It makes me wonder about the threads that tie us together, often without us ever knowing. If this story is touching a chord with you, I'd be so grateful if you could tell me in the comments what city you're listening from. It's a beautiful thing to remember that these moments of human connection, even the painful ones, are being shared and felt by people all over the world right now. The next 20 minutes were a blur of controlled, frantic activity, a stark contrast to the heavy silence Dr. Thorne had left behind. I administered the additional sedative to Mr. Finch, my hand steady, despite the tremor I felt in my own soul. His mumbling ceased, and he slipped into a more peaceful, pre-anesthetic slumber, completely unaware of the emotional earthquake he had set in motion. Sarah, however, was a live wire of anxiety. "What was that? What happened? Why did the doctor leave like that?" she asked me, her voice pitched high with fear. I offered her the only comfort I could, a half-truth wrapped in professional assurance. The pre-op medication can sometimes cause confusion and vivid memories. It's not uncommon. Dr. Thorne had to prepare for the surgery. Everything is proceeding exactly as it should be. The lies felt like ash in my mouth, but my primary duty was to my patient and his family's stability. I couldn't tell her that her father's cry for his own son had inadvertently plunged his surgeon into a waking nightmare. I escorted her to the surgical waiting area, promising updates, my heart aching at the forced, hopeful smile she gave me. When I arrived in the operating theater scrub room, the air was different. It was always a space of intense focus, a sacred, sterile chamber where the outside world was shed along with street clothes. But today, the focus had a sharp, brittle edge to it. Dr. Thorne was already there, scrubbing his hands and forearms with the methodical, brutal intensity of a man trying to scour away not just germs, but memory itself. The water was scalding hot, steam rising around him, yet his face was pale and set in a grim, unyielding mask. He didn't acknowledge my presence. The rest of the team, the anesthesiologist, the perfusionist, the other nurses, moved around him with a heightened awareness, like gazelles sensing a predator in their midst. The usual low hum of pre-op chatter was absent, replaced by the hiss of the water and the clatter of instruments being laid out with excessive care. We all felt it. The center of our universe, the calm, unwavering star we all orbited around, was vibrating on the verge of collapse. Mr. Finch was wheeled in, asleep, his body a still and vulnerable landscape under the bright, unforgiving lights of the OR. The transfer from the gurney to the table was performed with seamless, practiced efficiency. Tubes were connected, monitors were beeped to life, his chest was prepped and draped in sterile blue. It was a ballet I had witnessed 1,000 times, but today, every movement felt precarious. I took my position, my eyes constantly flicking from the patient's vital signs on the screen to the man standing across from me, gowned and gloved, a scalpel in his hand. Dr. Thorne's hands. They were his instruments of genius, known for their preternatural steadiness. But as he reached for the scalpel that the scrub nurse presented, I saw it, a tremor. A faint, almost ghostly quiver in his fingertips. It was there for only a second before he firmed his grip, his knuckles pressing white against the latex of his gloves. My blood ran cold. A surgeon's hands are his voice, his soul, his everything. That tremor was a scream. He made the initial incision. It was clean, precise, a perfect line down the sternum. But the energy was wrong. The confident, fluid economy of motion was gone, replaced by a rigid, almost mechanical precision. He was thinking about every movement, a conscious effort where before there had been only instinct. It was like watching a master pianist play a complex sonata by reading each individual note from a sheet of music instead of feeling the music flow through him. The first part of the procedure, the opening of the chest and the exposure of the heart, proceeded, but the atmosphere in the room was thick with a collective, unspoken dread. We were a well-oiled machine, but our central cog was grinding, threatening to seize. He worked in a profound and terrifying silence, not issuing his usual. The anesthesiologist had to ask twice for confirmation on heparin dosage, a simple query that was normally anticipated and answered before it was fully asked. Then came the moment of truth. The heart-lung bypass machine was primed and ready. The perfusionist gave the signal. Dr. Thorne's task was to cannulate, to connect the great vessels of Mr. Finch's heart to the machine that would take over the work of his lungs and heart, allowing the surgeon to operate on a still, bloodless field. It is one of the most delicate, high-stakes parts of the entire procedure. A single slip, a millimeter of error, and the consequences are catastrophic. I was watching his hands, my own breath held, praying for the steadiness to return. He positioned the cannula. His fingers, which had navigated this terrain 1,000 times, seemed to hesitate. And in that hesitation, his gaze, which had been locked on the intricate anatomy before him, flickered upward for a fraction of a second, towards the patient's face, obscured by drapes and equipment. He wasn't seeing Mr. Finch anymore. He was seeing a ghost. He was hearing a whisper. Lucas. The name seemed to echo in the silent, sterile space, a phantom sound that only he and I could hear. The tremor returned, more pronounced this time. The tip of the cannula, which needed to be placed with the absolute precision of a key entering a lock, wavered. It was a tiny movement, invisible to anyone not watching, with the intensity of a hawk, but to me, it was as dramatic as an earthquake. Time seemed to stretch, to distort. I saw the battle in his eyes, a war between the profound, resurrected grief of a father and the disciplined, life-saving duty of a surgeon. The two identities were tearing him apart right there on the operating floor. He closed his eyes for a beat too long, a cardinal sin in the middle of such a procedure. When he opened them, there was a new, desperate resolve in them, a white-knuckled clenching of his will. He forced his hand to still and completed the cannulation. It was technically correct. The bypass was initiated, the machine whirring to life, taking over the rhythm of Mr. Finch's existence. But the victory felt hollow, fragile. The point of no return had been passed, not just for the patient on the table, but for the man trying to save him. The great event that changed everything was not a single dramatic error, but the terrifying, undeniable realization that had just settled over the entire operating room like a shroud. The ghost in the room now had a scalpel. The next hour was an eternity of suspended terror, a high wire act performed over an abyss that only I seemed able to see. With Mr. Finch's heart and lungs now under the mechanical stewardship of the bypass machine, the true, intricate work could begin. But the surgeon's hands, those instruments I had always seen move with the grace of a natural force, were now betraying him in subtle, terrifying ways. It wasn't a dramatic, flailing incompetence. It was a loss of that effortless, fluid artistry that separated a good surgeon from a great one. Every suture, every delicate movement to graft the new blood vessels onto the struggling heart was executed with a rigid, conscious effort. He was fighting his own muscle memory, wrestling with his own genius, and the strain was palpable in the set of his shoulders and the tense silence that had replaced his usual quiet commands. The rest of the team adapted around him, a silent, desperate dance. The assisting resident, a young Dr. Evans, began anticipating needs and speaking up more, trying to fill the void of leadership without overstepping, his eyes frequently darting to me with a look of shared, panicked understanding. I became his silent partner, my role evolving from a cardiac nurse to a guardian of the emotional field. My focus split between the objective data on the monitors and the subjective, crumbling state of the man holding the fate of another in his trembling hands. My primary challenge was a constant internal triage of crises. Mr. Finch's physiology was, thankfully, holding stable under the immense stress of the procedure, but I watched his vital signs with an almost paranoid intensity, knowing that any sudden dip or anomaly would require a swift, decisive response from a surgeon whose decisiveness was currently compromised. But the greater, more immediate threat was Dr. Thorne himself. I saw the way he would occasionally freeze for a microsecond, his gaze losing focus on the intricate coronary anatomy and turning inward to that private, painful landscape where a baby named Lucas lived and died in the same moment. In those fleeting pauses, the entire operation hung in the balance. My interventions became a delicate, unspoken language. When I saw his hand hesitate before making a critical cut, I would speak, my voice calm and clear, narrating a stable vital sign or confirming an instrument count, not for the record, but for him. I was throwing verbal lifelines, using the solid, predictable language of clinical data to anchor him back to the present, to the tangible reality of the operating table and not the phantom pain of his past. It was an exhausting, soul-draining vigil, a constant battle against an invisible enemy that was steadily eroding the foundation of the entire procedure. The most harrowing moment came during the anastomosis of the final bypass graft, a procedure requiring the suturing of a vessel barely a few millimeters in diameter. It is a task of supreme patience and steadiness, a test of a surgeon's nerve and skill. Dr. Thorne's hands were sweating inside his gloves. I could see the moisture beading on his forehead, wiped away by the scrub nurse with a tense, worried efficiency. He began the suture, and for the first few passes, it was adequate, but it lacked his characteristic flawless precision. Then, as he was tying a critical knot, his fingers, which needed to apply consistent, gentle tension, suddenly jerked. It was a minute movement born of a fatigued muscle or a sudden, intrusive memory. I couldn't tell which. The suture line puckered slightly. It wasn't a catastrophic failure, not a torn vessel, but it was a flaw. A flaw in a Dr. Thorne procedure was as unthinkable as the sun not rising. He stared at the imperfection, and I saw a wave of something akin to pure shame and horror wash over his face, visible even above the surgical mask. His eyes met mine for a fractured second, and in them, I saw the devastating realization that he was failing, that his grief was actively compromising his ability to heal. "Suction," he ordered, his voice a gravelly, strained thing. And the moment passed as he corrected the minor flaw with a series of rushed, aggressive movements that were so unlike his usual calm control. The repair was made, but the damage to his confidence was done. The air in the OR, already thin with anxiety, now felt suffocating. The challenge for me was no longer just about managing his focus. It was about managing the spiraling despair I could see consuming him. He was trapped, a prisoner in his own operating room. He couldn't leave. A patient's chest was open, his heart stilled, his life literally in his hands. But he also couldn't fully be present because the ghost of his son had taken up residence in the sterile field, a spectral presence that clouded his judgment and stole the steadiness from his hands. I felt a profound, aching helplessness. I was a nurse trained to handle physiological crises, to administer medications, to offer comfort. But how do you medicate a 20-year-old grief that has just been violently resurrected? How do you offer comfort to a man who is actively watching his professional identity, the very pillar of his being, crumble under the weight of a single whispered name? My own heart was pounding a frantic rhythm against my ribs, a counterpoint to the steady, artificial beat of the bypass machine, each of us in our own kind of failure, fighting a battle on a field we had never been trained to navigate. And then the monitors screamed. It wasn't a gradual change, but a violent, digital lurch that seized the entire room in a grip of pure, undiluted terror. The arterial line pressure, which had been holding a steady, rhythmic wave, plummeted into a flat, ominous valley. A sudden, catastrophic drop in blood pressure. My own heart seemed to stop in sympathy. My eyes, which had been fixed on Dr. Thorne's hands, snapped to the screen, absorbing the data in a single horrifying instant. The EKG complex widened grotesquely, a sign the heart was becoming ischemic, starved of the blood flow we were supposedly restoring. The flaw in the suture line, it had to be. A tiny, imperfect knot had given way under pressure, or a nearly invisible tear had propagated, and now Mr. Finch's heart was drowning in its own inability to function. The delicate grafts we had spent hours meticulously attaching, now potentially leaking the very life they were meant to deliver. The calm, mechanical whir of the bypass machine suddenly sounded like a countdown to a death we had all worked so desperately to prevent. The reaction in the room was instantaneous and electric. The anesthesiologist began calling out numbers, his voice sharp with alarm. His hands moving swiftly to adjust drips, to push powerful medications in a desperate attempt to shore up the collapsing cardiovascular system. The perfusionist called out pressures from her console, her tone tight. BP 60/30, SVO2 dropping critically. All eyes, inevitably, swung to Dr. Thorne. This was the moment. This was the crucible where a surgeon is forged or broken, where instinct and training must eclipse everything, fatigue, doubt, and especially grief. For a long, agonizing second, he was utterly still, staring into the open chest cavity as if he couldn't comprehend the landscape of crisis before him. The data, the alarms, the frantic energy of the team, it all seemed to bounce off the impenetrable shell of his personal shock. He was a statue of a surgeon, his gloved hands hovering uselessly over the surgical field. And in that pause, I felt the precious seconds of Mr. Finch's life slipping away, each one an eternity. "Robert!" The word was out of my mouth before I could even think, a desperate, unprofessional breach of protocol that shattered the hierarchy of the OR. I didn't call him doctor. I used his first name, a plea from one human being to another. "The pressure's crashing. It's the anastomosis. You have to look." My voice was raw, stripped of all its professional calm, filled with a terror that was for both the man on the table and the man standing over him. It was that raw humanity in my voice that finally seemed to penetrate the fog. He flinched as if I'd struck him, his head snapping up, his eyes meeting mine across the sterile field. And in that gaze, I saw the final, brutal war. I saw the ghost of Lucas, a tiny, silent figure demanding his father's grief. And I saw Mr. Finch, a grandfather, a father himself, whose life was literally ebbing away with every beat of the faulty bypass machine. It was the father versus the healer, and only one could win. Something in him broke then, but it wasn't a collapse. It was a shattering of the dam holding back the surgeon he truly was. A profound, terrifying clarity washed over his face, burning away the haze of grief and replacing it with a focused, incandescent fury, not at us, not at the patient, but at the situation itself. The tremor in his hands vanished, replaced by a steadiness that was more profound and more frightening than anything I had ever seen. It was the absolute stillness of a predator, of a mind that has shut down every non-essential function to solve a single critical problem. "Suction, now," he commanded, his voice low and guttural, but utterly clear. "Evans, retract here. I need visual. Margaret, get me a fresh graft, now." The orders were crisp, absolute, and they galvanized the room. The spell was broken. The surgeon was back, but he was a different kind of surgeon now, forged in this moment of extreme duress. Operating not from a place of detached genius, but from a place of furious personal necessity. What followed was a breathtaking, high-stakes ballet performed at the edge of a cliff. He didn't meticulously re-examine the graft, he knew. With a speed that seemed to defy physics, he isolated the leaking anastomosis. The flawed suture line had indeed partially dehisced, a tiny but fatal fountain of blood welling up from the connection. There was no time for the careful, considered repair of before. This was damage control. This was salvage. His hands moved with a blinding, brutal efficiency, cutting away the damaged section of the graft and the native vessel with decisive sweeps of the scalpel. There was no hesitation, no inward-looking pause. His entire universe had collapsed into the few square centimeters of tissue in front of him. The only sound was his voice, issuing terse commands, and the frantic yet hopeful activity of the team responding to them. He worked with a kind of sacred rage, as if by saving Mr. Finch, he was somehow atoning for the son he could not save, as if every perfect stitch he placed now was a rebuttal to the single, imperfect one that had nearly cost a life. It was the most intense, emotionally charged piece of surgery I have ever witnessed, a performance driven not by ego, but by a desperate, profound redemption. The repair, the new anastomosis, was completed in a fraction of the normal time. It was, against all odds, a work of art born from chaos. "Initiate weaning from bypass," he ordered, his voice still tight, but now laced with a thread of exhausted hope. The moment of truth arrived as the bypass machine slowly handed the work of circulation back to Mr. Finch's own newly repaired heart. We all watched the monitors, our collective breath held. The flat line of the arterial pressure wavered, then jumped. It stuttered, found a rhythm, and then began to climb. 60 over 40, 70 over 50. 80 over 60. It was rising, a beautiful, steady ascent back to life. The EKG complex narrowed back into a healthy, familiar shape. The crisis was over. Mr. Finch's heart was beating, strongly and on its own, the grafts holding, delivering blood and a future. A palpable, almost physical wave of relief washed through the OR, so potent it left me feeling weak-kneed. The final steps of closing the chest were performed in a silence that was no longer tense, but awestruck and deeply weary. Dr. Thorne completed the closure himself, his movements once again fluid and economical, the ghost in the room finally, silently laid to rest. He stepped away from the table without a word, stripping off his gloves and gown and leaving the OR before we had even transferred Mr. Finch to the recovery gurney. The door swung shut behind him, and we were left in the bright, humming silence, surrounded by the evidence of a miracle that had been pulled back from the very brink of a tragedy that was decades in the making. Witnessing a moment like that, where the deepest human pain collides with the highest calling to heal, reminds me how connected we all are by these unseen threads of struggle and resilience. This story was born in the silence of an operating room, but its echoes are felt everywhere people face their own impossible choices. If this journey has resonated with you, I would be so honored if you'd consider subscribing to the channel, and perhaps, if you feel comfortable, share a little of your own story in the comments below. A time you found strength you didn't know you had, or a moment where a memory shaped your present in a powerful way. Your experiences are what make this community so special, and I read every single one, always moved by the incredible strength people carry within them. The aftermath in the OR was a landscape of spent adrenaline and quiet awe. The frantic energy that had consumed us just moments before had dissipated, leaving behind a profound, humming stillness. Mr. Finch's chest was closed, the stark line of sutures a testament to the brutal battle that had just been waged, not just on his heart, but on the soul of the man who had saved him. His vital signs, now strong and steady, painted a green and blue picture of stability on the monitors, a beautiful lie that hid the chaos we had just endured. The team moved with a new, subdued purpose, cleaning up, documenting, preparing Mr. Finch for transport to the cardiac ICU. There were no celebratory words, no sighs of relief spoken aloud. We communicated in glances and nods, a silent understanding passing between us all. We had witnessed something sacred and terrifying, a man pulling his own spirit back from the abyss to perform a miracle with his hands. I felt a deep, bone-level exhaustion. The kind that comes not from physical labor, but from having held your entire being taut as a bowstring for what felt like an eternity. My primary focus shifted seamlessly from the surgeon back to the patient. I accompanied Mr. Finch to the ICU, my hand resting lightly on the side of the gurney, a silent promise that he was still being watched over. The transfer of care to the intensive care unit nurses was detailed and thorough, but I found myself lingering, double-checking the settings on his ventilator, the drip rates of his medications, as if my continued vigilance could somehow cement the fragile victory we had snatched from the jaws of disaster. Sarah was waiting just outside the ICU doors, her face a mask of sleepless anxiety. When I approached her, the words, "The surgery was a success, he's stable and in recovery," felt both completely true and utterly inadequate. They couldn't convey the price that had been paid in that room. She burst into tears, this time of relief, and hugged me tightly, her gratitude a painful reminder of the normal, beautiful outcome that had nearly been lost. "Thank you, thank you, thank you," she whispered into my shoulder, and I just held her, accepting a thanks that felt like it belonged to someone else, to the man who had disappeared down the hallway. It was only after I had ensured Mr. Finch was settled and his daughter was comforted that I allowed myself to think about Dr. Thorne. The question of where he had gone hung over me, a heavy, unresolved chord. He wasn't in the surgeon's lounge. He wasn't at the computer stations updating the patient chart. A deep, instinctual pull led me away from the bright, busy hubs of the hospital and toward the one place I thought he might have sought refuge. The hospital chapel was always open, a small, non-denominational room tucked into a quiet corner on the first floor, a place that smelled of old wood and faintly of candle wax. The door was slightly ajar. I pushed it open slowly, the quiet click of the latch sounding like a gunshot in the profound silence. He was there, but he wasn't praying. He was simply sitting in the last pew, still in his scrubs, his forearms resting on his knees, his head bowed so low I could see the vulnerable nape of his neck. He looked utterly spent, a sculpture of defeat and solitude. The imposing figure of Dr. Robert Thorne was gone, replaced by a man who seemed smaller, older, hollowed out. I stood there for a long moment, unsure whether to intrude or to leave him to his private Gethsemane. But the memory of his hands, first trembling and then moving with that furious, salvational grace, compelled me forward. I walked softly down the short aisle and sat in the pew in front of him, turning slightly so I could see his profile. We sat in silence for what felt like a long time, the only sound the distant, muffled hum of the hospital's life support system. When he finally spoke, his voice was raspy, stripped raw, and so quiet I had to lean forward to hear him. He didn't look at me. His name was Lucas, he said, the words not much more than an exhalation, a confession offered to the quiet, holy space. He had his mother's nose, 10 perfect fingers, 10 perfect toes. He took one breath, a small, gasping thing, and then he was just gone. The clinical details of a 2-decade-old tragedy, details I had only ever heard in whispers, were now being laid bare by the only person whose opinion of them mattered. We never got to bring him home. The car seat remained empty. The nursery door stayed closed. And I came here, to this hospital. I thought if I could just save enough of them, if I could fix enough broken hearts, maybe it would somehow matter, that his one breath would have meant something. He lifted his head, Ben, and his eyes were red-rimmed and shattered, but for the first time, they held no walls. He was looking at me, truly seeing me, and the shared experience of the last few hours had forged a connection that transcended our professional roles. In there, he continued, his gaze drifting toward the door, back in the direction of the OR, when he said that name, it was like a bullet. It tore through everything. For a moment, I wasn't a surgeon. I was just a father in a room where someone else was calling for a son I never got to hold. And then I failed. My hands, Margaret, my hands failed. The admission was agonizing for him, a violation of his most fundamental identity. But they didn't, I said, my own voice soft but firm. In the end, Robert, they didn't. You came back. You saved him. He shook his head, a slow, weary motion. I didn't come back as the same man. That man is gone, the one who thought he could outrun grief with competence and silence. He let out a long, shaky breath. What came back was angrier, more desperate. I wasn't fixing a heart for medicine. I was fixing it for Lucas, as if saving that old man could somehow travel back in time and save my boy. He looked at his hands, turning them over as if seeing them for the first time. It was the most unprofessional, emotionally compromised surgery of my life, and yet it was the most honest. This was the beginning of the resolution, not a neat tying of a bow, but the first painful steps out of a deep and dark forest. The conflict wasn't magically over. The ghost of Lucas would always be there. But the power it held over him had been fundamentally altered in that operating room. It was no longer a silent, shameful secret that controlled him from the shadows. It was now an acknowledged, painful part of him that he had been forced to integrate, a wound that he had to operate around, not ignore. By speaking the name, by admitting the failure and the subsequent desperate redemption, he had begun the real work of healing, his own. We sat together in that quiet chapel for a long while, not as nurse and surgeon, but as two witnesses to a profound human reckoning, watching as the path forward, difficult and uncharted, slowly began to reveal itself in the quiet light of the afternoon. The silence in the chapel was a living thing, a balm after the screaming alarms and the frantic, desperate energy of the operating room. We sat there for what felt like an hour. Though it was probably only a handful of minutes, the weight of his confession settling between us like sacred ground. Finally, Robert stirred, the movement slow and heavy, as if he were moving through deep water. He pushed himself to his feet, his joints cracking in the quiet. He didn't look at me, but he paused beside my pew. "Thank you, Margaret," he said, his voice still rough, but now carrying a new, fragile sincerity, for calling me back. It was all he could offer, and it was more than enough. I simply nodded, watching as he walked out of the chapel, his posture not the unassailable fortress of Dr. Thorne, but the weary, human slope of a man who had finally set down a burden he'd carried for 20 years. The door whispered shut behind him, and I was left alone with the echo of his truth. The rest of my shift passed in a blur of mundane tasks, but my mind was back in that OR, reliving every heart-stopping second. I checked on Mr. Finch in the ICU multiple times. His recovery was progressing better than any of us had dared to hope. His heart was strong, the grafts were holding, and by the next evening, he was awake, lucid, and asking for a cup of tea, much to his daughter Sarah's tearful relief. It was a perfect textbook outcome, a fact that felt like a small miracle in itself. I never saw Dr. Thorne visit the ICU that day. I learned later that he had gone home, something he almost never did after a major surgery. Instructing his resident, Dr. Evans, to manage the post-op care. It was the first crack in his armor that the rest of the hospital would see. The first public admission that he was, in fact, human. The true conclusion to this story, the how of that initial shattered silence in the pre-op room, didn't happen in a single dramatic moment. It unfolded over the following weeks and months in subtle, profound shifts. Robert Thorne returned to work, but the man who walked the halls of St. Jude's was different. The intimidating, marble-carved silence was gone. He wasn't suddenly gregarious, but he was present. He would nod to nurses in the hallway, sometimes even making brief, quiet eye contact. He started holding his pre-op consultations in the patient's room, sitting down in a chair instead of standing over the bed like a clinical deity. His speeches were no longer just dispassionate lists of success rates and procedural facts. They included gentle questions about a patient's family, their fears, their hopes for life after recovery. He was no longer just fixing organs, he was healing people, and in doing so, he was finally beginning to heal himself. I was assigned to his team for another complex procedure a month later. The atmosphere in the OR was different from the start. There was a calm focus, but the brittle, walking on eggshells tension was gone. Robert's hands were steady, but it was a new kind of steadiness. Not the cold, detached precision of a machine, but the grounded, mindful calm of a man who had made peace with the tremors that lived within him. At one point during a delicate part of the surgery, the patient, an elderly woman, murmured something incoherent under her breath. I saw Robert's shoulders tense for a fraction of a second, a fleeting ghost of a memory crossing his features. But then he took a soft, deliberate breath, his eyes never leaving the surgical field, and his hands never wavered. He had learned to acknowledge the ghost, to let the memory of Lucas exist in the room without allowing it to take the scalpel. He had integrated his pain into his purpose, and in doing so, had become an even greater surgeon, one whose genius was now tempered with a profound and hard-won empathy. The final piece of the resolution came on a quiet Tuesday afternoon. Mr. Finch was being discharged, his recovery nothing short of remarkable. He was in a wheelchair by the main entrance, bundled up against the slight chill, with Sarah beaming beside him. As they were preparing to leave, Robert Thorne walked through the sliding doors, having just finished a clinic. He saw them and, to my astonishment, he stopped. He walked over to Mr. Finch and crouched down beside his wheelchair, bringing himself to the old man's eye level. "I'm glad to see you looking so well." "Alistair," Robert said, his voice quiet and sincere. Mr. Finch, his mind clear and his spirit buoyant, smiled warmly. "Thank you, Doctor. I feel like a new man. I owe you my life." Robert held the old man's gaze for a long moment, and I saw a universe of understanding pass between them. "We all have our battles," Robert replied, his words weighted with a meaning only he and I fully understood. Then he did something I had never seen him do in all my years at the hospital. He reached out and placed his hand over Mr. Finch's, a simple human gesture of connection. You take care of yourself. He stood up, nodded to a bewildered but grateful Sarah, and continued on his way. In that simple act, the use of the patient's first name, the shared look, the touch, the last of the fortress walls crumbled into dust. The wound was not gone, but it was no longer bleeding. It had scarred over, strong and resilient, a part of him, but no longer the definition of him. This journey, which began with a single, devastating whisper, taught me more about the human heart than any textbook or EKG strip ever could. It taught me that the deepest wounds are not always the ones we can see, and that the most profound healing often happens in the hidden, quiet places of the soul. Robert Thorne spent 2 decades trying to outrun his grief by saving countless lives, believing that if he could just be perfect enough, clinical enough, he could silence the pain of that single lost breath. But grief is a stubborn tenant. It doesn't leave just because you refuse to acknowledge it. It waits in the silence, and eventually it will speak, often in the most inopportune and devastating of ways. The miracle wasn't that he avoided his pain. The miracle was that when it finally ambushed him in that sterile pre-op room, he found a way, against all odds, to not let it destroy him or his patient. He allowed his professional identity to shatter so that his humanity could finally emerge, scarred and broken, but infinitely more whole. The moral of this story is not that we should be strong enough to avoid breaking. It is that our greatest strength is often found in the way we put ourselves back together after we have fallen apart. It's about the redemption that can be found not in perfection, but in honest, flawed, and desperate effort. Robert didn't save Mr. Finch because he was a flawless surgeon. He saved him because, in his moment of ultimate brokenness, he chose to channel his love for his lost son into the act of saving another father, another grandfather. His love for Lucas, which had been a source of silent, festering pain for so long, became, in that critical moment, his source of ultimate strength. It is a spiritual truth I carry with me every day on the ward, that our traumas and our joys, our deepest losses and our greatest loves, are not separate from our work or our purpose. They are the very threads that weave the tapestry of who we are, and when we have the courage to integrate them, to stop running, and instead turn and face them, we don't become weaker professionals or more fragile people. We become healers in the truest sense of the word, capable of mending not just bodies, but the invisible, broken places within the human spirit. The ghost in the room will always be there, but it doesn't have to hold a scalpel. It can, instead, be the quiet, compassionate witness that reminds us of the profound, fragile, and beautiful cost of a single precious life.